Hello everyone and welcome to this week's VJOncology podcast. This week's episode focuses on immuno-oncology highlights in head and neck cancer from this year's ASCO conference. Firstly, we have Barbara Burtness from the Yale School of Medicine who presents data from the Origami-4 trial, which evaluated subcutaneous amivantamab in recurrent or metastatic head and neck squamous cell carcinoma.
Origami-4 is a multi-cohort study that's looking at the EGFR-MET bispecific antibody in head and neck cancer. So this use of EGFR inhibition in head and neck cancer is pretty well established. Cetuximab is a monoclonal antibody to EGFR that's been used either in treatment refractory disease, including after immunotherapy, or in combination with radiation. But we've understood for a long time that MET can upregulate after you inhibit EGFR and that MET signaling mediates resistance. So it's been of interest to see if co-targeting EGFR and MET would be of utility in head and neck cancer. What I presented at ASCO this year was the final full results from cohort 1. This looked at amivantamab alone in patients with recurrent metastatic head and neck squamous cell carcinoma that had previously been treated with an immune checkpoint inhibitor and a platinum chemotherapy agent. And so this is a pretty treatment refractory population. There are not other agents that have high response rates here. And we saw a blinded independent central review confirmed objective response rate of 42%, very similar to the investigator assessed response rate of 47%. There were 15% of participants who had a complete response. Responses were pretty durable. The median duration of response hadn't been reached. And the overall survival was very impressive at 12.5 months. If you look at cetuximab, the sort of other EGFR inhibitor, in the post-immunotherapy setting, that has a median overall survival of 8.6 months. So it looked as if this was pretty active. We used a subcutaneous formulation of amivantamab here. So the older data in lung done with an IV formulation, there were a lot of infusion-related reactions. Here we had administration-related reaction rate of 15%, and they were all grade 1 or 2. There were no grade 3 administration reactions. There was one on-study death due to pneumonitis, but overall this appeared to be very safe, no new safety signals compared with other data with subcutaneous amivantamab, and a very, very impressive amount of clinical activity. So the data were simultaneously published in JCO. People can, see all the details, and also have been submitted to the FDA. We're also taking this forward in the first-line setting. So I mentioned Origami-4 is a multi-cohort study. Cohort 2 looked at amivantamab and pembrolizumab in first-line. That has been previously orally reported at the head and neck multidisciplinary meeting, has a response rate of 56%. And the phase 3 trial is going to take that forward with chemotherapy. So patients don't need to be PD-L1 selected, first-line recurrent metastatic disease, and they'll be randomized between chemo-pembro a la KEYNOTE-048, or they'll get carboplatin, pembrolizumab, and amivantamab. And that phase 3 study is ongoing.
Dr. Burtness also discusses findings from the subgroup analysis of the KEYNOTE-412 trial, which assessed chemoradiotherapy with or without pembrolizumab in locally advanced head and neck squamous cell carcinoma.
KEYNOTE-412 was one of the large phase 3 trials that looked at the question of whether or not immune checkpoint inhibition could improve survival when added to definitive chemoradiation. And I think it had some advantages over some of the other studies that had been reported out as being negative. One was that it was a very large study, so it seemed like it was adequately powered. And another was that it used a PD-1 inhibitor, which was a validated agent that had already been shown in recurrent metastatic disease to improve survival, as opposed to some of the other studies that use PD-L1 inhibitors that have not entered the standard of care in head and neck cancer. But KEYNOTE-412 was negative, and it was pembrolizumab did add numerically in terms of disease control, event-free survival, overall survival, but it did not meet the prior statistical hypotheses, and it was not judged to be a positive trial. With longer follow-up, the curves have continued to separate, and so the 5-year follow-up data have previously been presented. But one of the quirks of the KEYNOTE-412 trial was that it did accept patients who had, first of all, a variety of sort of prognoses or risk of recurrence. So there were both HPV negative and HPV associated cancers included. And it included stage 3 and stage 4 patients. And then it included both those patients whose tumors express PD-L1, where we expect pembrolizumab to work, and those where the tumor did not express PD-L1, where maybe we don't expect pembrolizumab to work. So what we did here was, with the long-term follow-up, we now did a subgroup analysis focused on the PD-L1 rich tumors, those with a combined positive score for PD-L1 of 10 or higher. And what we found here was that it looked like pembrolizumab was delivering quite a significant advantage, 12% difference in 5-year event-free survival, 10% difference in 5-year overall survival. And in both cases, although these were unplanned subset analyses and we don't have p-values, the confidence intervals were under 1. So I think the question here is, did the quirks of the design of 412 end up not delivering an answer, even though pembrolizumab is benefiting higher risk patients with PD-L1 expressing cancer? So if we looked at the HPV associated cancers, the hazard ratios were around 1. If we looked at the stage 3s, not much benefit, but a pretty impressive benefit for the CPS 10, probably concentrated in the HPV negative higher stage patients. So I think the question is whether these data will be accepted by NCCN or ESMO guideline committees as something to discuss with patients who have high-risk disease and high PD-L1 expression, because it looks as if there might be something like a 10% survival advantage, and we wouldn't want to withhold that from patients.
Next, Hannah Kenny from Thomas Jefferson University Hospital presents results from a phase 2 trial of neoadjuvant cemiplimab for resectable hedgehog inhibitor-naive basal cell carcinoma.
Yes. So overall, our primary endpoint of this study was looking at objective response rate and disease control rate among patients with locally advanced HHI-naive basal cell carcinoma of the head and neck. The objective response rate was 60%, and the disease control rate was around 91%, which sets it at similar to better efficacy profile as compared to hedgehog inhibitors, which are currently the standard of care first-line systemic treatment for this disease. That being said, the safety profile of this treatment was very favorable in comparison to the standard of care. So there was one grade 3 or higher treatment-related event at less than 3%, and only 12 patients experienced any treatment-related adverse event, the rest of which were grade 1 to 2. Additionally, patients were able to undergo less morbid surgery as compared to what they would have been at starting out in the trial. And so that was another secondary endpoint that we found benefit in. And so about 40 or greater, just over 40% of patients were able to undergo a lesser surgery than they would have at the beginning of the trial in response to that neoadjuvant cemiplimab treatment.
Following on, Ari Rosenberg from the University of Chicago discusses results from the EV202 trial of enfortumab vedotin plus pembrolizumab for frontline PD-L1 positive recurrent or metastatic head and neck squamous cell carcinoma.
This was a single-arm cohort from the EV202 study that looked at the combination of enfortumab vedotin, which is a Nectin-4 targeted ADC, with pembrolizumab for frontline PD-L1 positive recurrent metastatic head and neck cancer. The objective response rate was 39%, so better than we expect with pembro alone, similar to the responses that we see with chemo-pembro. What was interesting that the responses were enriched for HPV positive patients, so suggesting that further testing of antibody drug conjugates target Nectin-4 is warranted in patients, particularly in the HPV positive or in patients with oropharynx primary as well. We did present also data from a drug called CRB-701, which is a next generation Nectin-4 targeted ADC, which quite promising single agent activity in immunotherapy and platinum chemotherapy refractory patients, particularly in those with oropharynx or HPV positive oropharynx. And so we're excited to see more data looking at ADCs targeting Nectin-4 and other targets, particularly in oropharynx and particularly HPV associated oropharynx cancers as well.
Dr. Rosenberg also explores findings from the Target HPV trial, evaluating neoadjuvant HPV-specific viral immunotherapy plus chemotherapy with response-adapted de-escalation in HPV-16-positive oropharyngeal squamous cell carcinoma.
This was an investigator-initiated trial where we tested HB200, which is an HPV-specific therapeutic vaccine in the neoadjuvant setting for local regionally advanced HPV-positive head and neck cancer. We gave neoadjuvant HB200 with chemo, followed by response stratified de-escalation. So deeper responders got de-escalated radiation or minimally invasive surgery alone. What we found was that the percentage of patients with a deep response, defined as over 50% tumor shrinkage, was 88% of patients, which was greater than the historical control of chemotherapy alone that we saw in our prior Optima trial, where it was around 70% of patients that achieved that. We also looked at circulating tumor HPV DNA dynamics. We identified the fact that patients who had detectable HPV DNA following treatment with an NGS-based assay had worse progression-free survival. We also looked at specific anti-tumor immunity. So the majority of patients actually expanded their T cells specific to the HPV neoantigens, which is the goal of what the therapeutic vaccine is trying to achieve. And then finally, we started to look at some spatial transcriptomic data, and we found that patients that had more organized, more mature tertiary lymphoid structures, particularly in the periphery of the tumor, seem to enrich for a deeper response on the clinical trial. So I think the big takeaways here is that there does seem to be some early signal that a neoadjuvant HPV therapeutic strategy may be beneficial for some patients. It does seem that either in combination with chemo or with PD-1 inhibitors, that there is a signal of efficacy for this strategy, but it needs to be continued to be investigated with better drugs that can do this, and with the current drugs to try to further develop these in larger trials and randomized trials to demonstrate a benefit for these patients.
In addition, Nabil Saba from Emory University discusses B-cell responses in patients with recurrent respiratory papillomatosis treated with DNA immunotherapy INO-3107.
So recurrent respiratory papillomatosis is a non-cancerous condition. However, it affects the quality of life of patients. It is mediated through the HPV virus, specifically HPV 6 and 11. And it affects the quality of life. It affects patients of all ages, particularly younger patients. And so recently there has been significant development in the tackling of this condition through systemic therapy. We've used VEGF inhibitors off-label, specifically bevacizumab, and that works very well as far as a non-surgical approach. Recently, we had the first approval of a DNA-based therapy, which is really an immunotherapy stimulating the immune system to attack the viral-mediated proteins. The agent that was approved is zopapogene, or Pepsi-Mayos. And so that's now available for patients, which is very exciting. Another agent that was tested in this agent is the agent in question here, which is the INO-3107. That is also a DNA-based therapy. And at this ASCO meeting, we're presenting the information related to the B-cell responses, specifically to giving this agent or this vaccine, tumor vaccine, really, to patients with this condition. So as we know, the T cell responses are really playing a major role in, we think, inducing an immunologic effective responses for these tumors. The fact that in this ASCO meeting we could show that also this treatment induces specific B cell responses, and those are induced and found in the blood, but also in the tissue for the few patients who were rebiopsied. And the increase in these B cells seems to correlate also with the clinical benefit to giving this agent. In other words, this correlated with the lack of need of surgical resection over the first and second year and beyond the second year. That indicates that probably these B cells are are enhancing the T cell activity and presenting antigens, perhaps to the T cells, to essentially improve the clinical activity of this agent. So we're very excited about this. There needs to be more work to further characterize this immunologic response. But this is a unique opportunity in enhancement of, the responses by these treatments to these patients. And we hope that more and more options will be available for these patients.
Finally, we spoke with Kedar Kirtane from Moffitt Cancer Center, who provides insight into emerging cell therapies for head and neck cancer, including tumor-infiltrating lymphocytes, CAR-Ts, and T-cell receptors.
I'm leading an ASCO education session this weekend on emerging cell therapies in head and neck cancer. I'll be discussing tumor-infiltrating lymphocyte or TILs, CAR-Ts, and TCRs. All of them are very early stage in clinical development. However, they are exciting prospects for the future. TILs have been studied for ages, and there's recently an FDA approval for metastatic melanoma with lifileucel, and we're trying to apply that same logic to patients with head and neck squamous cell cancers. Now, to give you a little bit of background, patients with metastatic disease have a very poor overall survival outcome. They, on average, live about 11 to 13 months, despite our best efforts. And we have one standard of care treatment, which is pembrolizumab, but that treatment only tends to work about 20% of the time. So 80% of the time, patients tend to have progression of their disease despite immune checkpoint inhibitor. TILs provide another way of activating T cells in order to try to improve upon response rates in patients with metastatic disease. The thought process is that although checkpoint inhibitors can allow T cells to interact with cancer and cause cancer regression, sometimes the tumor microenvironment makes it very difficult to do so. There are lots of inflammatory and immunosuppressive cytokines that are secreted by the microenvironment, which makes T cells maybe ineffective. And so what TILs allow us to do is we are able to take out these T cells, recharge them, and give them back to the patients in a way that will hopefully enact some changes. Yeah, so in the past, we've really focused on what we call bulk TIL, which is just taking lymphocytes from a patient's tumor and recharging them. The nice thing about that is that they're polyclonal. They have a heterogeneous antigen response. However, we don't know which T cells are really doing the work. And so the next stage is a couple of things. One is selective T cell enrichment, so focusing on figuring out which T cells are actually doing the work and recharging those specific T cells to improve upon bulk TIL. Another is adding interleukin support, and particularly membrane-bound interleukin can be helpful potentially. And then there's also neoantigen-directed TILs, which is really focusing on cancer-specific T cells that can help overcome the problems that bulk TIL may have. The new technologies are really fantastic, at least in theory. They can increase logistics, the complexity of the logistics involved, and many times patients may not have time. And so really the goal is to try to reduce the vein-to-vein time from TIL harvest to actually giving patients these newer methodologies. CAR-Ts are still very naive or early in stage as well. CAR-Ts are able to direct their targets towards surface antigens. Many solid tumors, including head and neck, tend to have heterogeneous antigen expression, so it becomes a little bit difficult to find one selective antigen to target. However, logic-gated CAR-Ts may overcome that problem and allow for a widening of a therapeutic window that otherwise would be narrow.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this episode, please leave a review and subscribe on your favourite podcast app, including Apple, Podbean and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology to join in the conversation, and visit VJOncology.com for the latest updates in the field.